everyone, and welcome to this exciting episode of MedSynapse podcast series. I'm your host, Edvisha, and today we're exploring an essential topic for clinicians, which is managing patients with chronic kidney disease, a complex interplay that poses unique treatment challenges and risks. And today we are honored to explore this critical topic with none other than Dr. Amitabh Kulkarni. Dr. Amitabh is a highly respected nephrologist practicing in Dubai, which with extensive experience in addressing a spectrum of kidney conditions. Over the past decade, he has been a leading voice in kidney health across the UAE, bringing an emphasis on preventive nephrology and patient-centered care. Not only is he deeply involved with key nephrology societies across the UAE and internationally, but his dedication to advancing kidney health is evident through his research, publications, and active participation in conferences worldwide. So, Doctor, welcome to the podcast, and we are so thrilled to have your expertise on such a vital topic today.
Yeah. Hello, Hetvi. Thank you. Thank you for having me on this platform. I'm very excited and happy to share the information, whatever I have, with the community. Thank you.
Absolutely. And I am very sure that our listeners are eager to gain from your insights on this. So, now to start off, Doctor, could you provide an overview of how hypertension and chronic kidney diseases are interconnected, and what would you say are some of the biggest challenges or barriers you can encounter when treating hypertension in CKD patients?
Yeah, definitely. Since today's topic is predominantly related to hypertension related to chronic kidney disease. See, chronic kidney disease is a kidney disease which is going on for at least 3 months with some sort of structural or functional damage within the kidney. Now, hypertension and CKD or chronic kidney disease are very, very closely related. There are multiple reasons for this. One of the commonest reason is the hypertension itself is a triggering cause or the main cause for chronic kidney disease. So many of the patients who has a pre-existing hypertension which is not controlled well can lead to a chronic kidney disease. So obviously their blood pressure which was being uncontrolled or irregularly controlled leads to chronic kidney disease. It has been observed that almost 60 to 80% of patients who has chronic kidney disease have a significant hypertension, and when it reaches the terminal stage or end stage renal disease, or what we call it as a dialysis stage for chronic kidney disease, almost 90 to 95% of the patients will have blood pressure. So the volume of the patients who are having high blood pressure with chronic kidney disease is very huge. So blood pressure control becomes very, very important in this situation. Now, if you ask me, if there are any other reasons for blood pressure in these patients, yes, there are multiple reasons, especially someone who has end stage renal disease with fluid overload, someone who is not very regular with medicine, not very regular with hemodialysis as advised. They tend to have higher blood pressure due to obvious reason. Sometimes there is a family history of high blood pressure, something which you can't do much about, but that is something like a familial predisposition to high blood pressure, which complicates the pre-existing chronic kidney disease. Very rarely, some patients will have a vascular disorders like vasculitis. Now, vasculitis is another disease which can cause kidney disease, eventually leading to chronic kidney disease. So, someone who has a vasculitis, they also tend to have high blood pressure, and which is a big issue while controlling their health in the course. So these are the common reasons why we do get this blood pressure in chronic kidney disease. Yeah, yeah. Now, coming to the challenges while treating this blood pressure. Now, chronic kidney disease, as I said, it's a disease which has happened over years together. So obviously, it's not a straightforward disease which can be treated with one or two medicines. So challenges are there for most of the chronic kidney disease associated blood pressure. Now, the most common challenge or barrier which we see is a compliance. Compliance in the sense the regularity of treatment. Many a times the patients are tired of treatment, patients are tired of taking pills, patients are tired of coming to dialysis as advised. If someone is a stage 5 chronic kidney disease and he has been asked to follow a certain schedule for dialysis, they sometimes they do not follow as per our expectation. So poor compliance is one of the, like, a very common reason for high blood pressure in these chronic kidney disease patient. Apart from poor compliance, many a times we see fluid overload or excessive salt and water consumption more than required in these patients, that can cause uh, elevated blood pressure in such situation. Skipping dialysis in end stage renal disease patient or stage 5 chronic kidney disease patient, that is another reason for high blood pressure. Sometimes the barrier can be due to some uncommon diseases like renovascular hypertension or renal artery stenosis. That can cause uncontrolled blood pressure in spite of multiple medicines in these patients. Very rarely, the medications which they are taking, like if they are taking, say, pain medicines, or they are taking erythropoietin, which is commonly used medicine with dialysis patient, that can also trigger high blood pressure in these patients. So these are various barriers which we see are not absolutely not treatable, but we have to be very, very careful when handling these situations.
Thank you for
Thank you.
that advice. I think there are multiple factors, as you mentioned, that interplay together and which actually affects. On that similar note, I would also like to ask that what would that one advice be, your advice be to clinicians that they can, interact with the patients when they face such barriers?
Yeah. Very, very practical and important question, Hetvi. Many a times when patient visits our clinic and we prescribe some medicine, we often forget the role of lifestyle modification or non pharmacological interventions, which we can actually use very, very effectively in these patients. As I said, the salt plays very important role for controlling blood pressure. In addition to salt, doing a moderate exercise as much as your body can tolerate, that definitely helps in controlling the blood pressure. Reducing weight itself can help in controlling blood pressure. So often we need to interact with them about their lifestyle modifications and what are other things which they are doing apart from consuming medicine. Many a times we have also seen that because of the pill burden, if they are taking multiple medicines at a time, they often skip medicines or delay the medicines, and that itself may cause the blood pressure. So they may not be consuming the medicines which are already prescribed, and for the fear of scolding, they may not reveal that to the doctor. Doctor may feel that okay, he's taking two medicines, it's still not control, add third medicine, add fourth medicine. So I think a good discussion with patient and patient's family is very, very important when you come across managing hypertension. And the role of non pharmacological measures for control of blood pressures, I would say, are equally important, especially in the early stage of hypertension for an effective control of high blood pressure. Yeah,
Yes,
thank you.
I think that is so rightly mentioned that only certain lifestyle modifications also can help a long way. So that is also very necessary. Now, I'd like to touch on the dialysis, something on dialysis now. So, does it impact blood pressure control in patients with hypertension, and if so, does it influence hypertension management in CKD patients?
Yes, yes, definitely. As I mentioned earlier, uh, in the course of chronic kidney disease, the dialysis stage is called as chronic kidney disease stage 5. So, and or it's also called as end stage renal disease. Now, almost it has been studied that almost 90 to 95% of the patients who are on dialysis will have blood pressure, and they are going to need some antihypertensive medicines. So blood pressure control in these cases is a very important. Now, why is it important? Because most of these patients who has a chronic kidney disease, they also have, or they are also at a higher risk for developing other complications related to blood pressure. It can be a cardiac disease, it can be a cerebrovascular disease, or it can be any other vascular disease, peripheral vascular disease. So blood pressure control is very crucial in these patients. Now, as I again I want to re-emphasize that a regular treatment, whether it is a medical medicines or hemodialysis or diet, compliance is very crucial in these cases. So if they are consuming the medicines on time, if they are following the the physician's advice related to the diet, and if they are doing a regular dialysis without skipping any session, uh, of course in addition to following the diet, definitely that will help in controlling the blood pressure. And not following, obviously it's going to complicate the control of blood pressure, which in turn can lead to various other complications, as I mentioned.
That is so interesting. So it's like sounds like dialysis can sometimes also helps, but also add another layer of complexity to managing blood pressure as well.
Correct. What happens is almost all of these patients with on dialysis, they are fluid overloaded, and fluid overload is one of the reason for hypertension in these patients. Now, when they come for dialysis, we remove some fluid during the dialysis. It's called as ultrafiltration. Now, removing an ultrafiltration itself will help in controlling the blood pressure. So, many a times we see that patient has come for dialysis session with a higher blood pressure and then goes back home with a normal blood pressure. So, definitely dialysis will help in controlling the blood pressure, provided all other factors are in place.
Yes, definitely. Now, also on that similar note, only my next question would be what do you see as the primary barriers clinicians face in maintaining BP control while minimizing nephrotoxic effects? And also, on some studies also suggest that aggressive blood pressure lowering can actually worsen renal perfusion. So, how do you balance the need for tight BP control without compromising renal function in these vulnerable patients?
Yeah, see, there is what is called as a U turn or U shape for blood pressure control. What does it mean? That if you are doing a very aggressive blood pressure control, and what is the meaning of aggressive blood pressure control? It shouldn't be lower than the target blood pressure. Now, most of these hemodialysis patient or CKD patient, they have a target of somewhere around 120 to 130 systolic with a diastolic of 80. Now, these are something which is set by our guidelines. The common guidelines which we as a nephrologist we follow is KDIGO guideline for high blood pressure. Of course, there are American guidelines, there are European guidelines. However, for chronic kidney disease, the usual target blood pressure is somewhere around 120 to 130 systolic and diastolic of 80 millimeters of mercury. Now, Excessive blood pressure control, what is the meaning? If you are lowering too low the blood pressure, especially during dialysis or on non-dialysis days, it has been studied and it has been observed that that has a detrimental effect on overall health, not just kidney. Because hypotension at home or hypotension during dialysis will have some negative effect on heart and brain, that itself in long run can have a cardiovascular or cerebrovascular damage. So and it has been studied, observed that a very low blood pressure or over aggressive blood pressure control in fact can increase mortality. So very high blood pressure as well as very low blood pressure, both can increase mortality in its own with its own mechanism. So a good blood pressure control, tight blood pressure control in the specified range is very crucial in these patients. The hurdle which we see or which we encounter uh, in day-to-day practice is again the fluid overload or excessive sodium consumption by these patients on dialysis. uh, Skipping dialysis sessions, again I am mentioning because it's as common as I am mentioning it in this talk. Yeah. uh,
Okay.
the third is skipping medicines. Many a times patient feels that no, my blood pressure, he may check blood pressure at home, oh my blood pressure is fine, so I don't need any more medicines now, and then they skip medicines. So skipping medicines is also a very common reason. And remember, this is something which unless we discuss with patient, is not going to we are not neither we are going to understand about it, neither they are going to understand the importance. So discussing with patients about this is very important. Many a times on dialysis patients, we use this injection called erythropoietin for control of anemia. That has a side effect of hypertension. So it's like we have to be very careful. We have to regularly monitor the dose. We have to control the hemoglobin with the minimum dose of erythropoietin so that it will avoid its uh, own side effect. And very rarely, as I mentioned earlier, renovascular hypertension or a renal artery stenosis sometimes can cause uncontrolled blood pressure in these patients. That may need a separate evaluation if you are suspecting with your clinical sense. Yeah.
Yes, yes, that makes a lot of sense. And I think rightly mentioned that right kind of communication with the patients also, I think it stops the challenges for the clinicians itself as
Right. Right.
so now, speaking of the individualized care that is necessary for managing hypertension in CKD patients, I would love to hear about your approach to selecting drug combinations in resistant hypertension cases. Specifically, or like how do you weigh the use of diuretics versus the agents targeting the RAAS systems?
Yeah. Starting antihypertensive medicine patient in CKD. Now, since we are discussing mainly CKD, because starting antihypertensive medicine itself can be a topic for discussion. But in chronic kidney disease patient, it all depends on what stage of kidney disease they are. If it is an end stage renal disease or chronic kidney disease stage 5, or someone who is on hemodialysis, I will discuss about that first. Um, in these patients, usually we start with either calcium channel blocker or beta blocker, either singly or combination. The reason is these are a relatively safe drug. They are metabolized well, especially in end-stage renal disease patient. It is easy to titrate their dose. Now, calcium channel blockers, which we commonly use, are amlodipine or nifedipine or lurkadipine. Or beta blockers, which we commonly use, are atenolol, sometimes metoprolol, or sometimes carvedilol or bisoprolol. Now, why we use this drug to begin with is because of probably the less side effect, although no medicine is without side effect, but with less side effect and a better studied molecule. Now, the next molecule which we tend to use in patient who has resistant hypertension or uncontrolled hypertension. The resistant hypertension is defined as when you give three medicines in full dose for a patient and his blood pressure is still uncontrolled. So that is something we label it as a resistant hypertension. So patient is taking three medicines in the maximum dose and still the blood pressure is not as per our goal. So the next medicine which we use is ACE inhibitor or ARBs. ACE inhibitor or ARBs are very popular drugs for control of blood pressure right from stage 1 up to stage 5. However, it has a side effect, especially hyperkalemia or high potassium, which is a side effect of chronic kidney disease stage 5 itself. So it's very carefully used drug in these patients, wherein we can use the medicine, but we have to regularly monitor their potassium. And if potassium is in the unacceptable range, more than 5.5 or 6, or if it is showing some ECG changes with high potassium, definitely we have to withdraw the drug and we may have to find out the alternative. Now, the ACE inhibitor or ARBs, ACE is angiotensin converting enzyme, and ARBs are angiotensin receptor blockers. Now, ACE are usually the one which we have been using is lisinopril, ramipril, sometimes captopril. ARBs which we use are usually losartan, valsartan, olmesartan. These are the commonly used drug which we use with the modified or corrected dose according to the patient's blood pressure. The next line of drug which we use is clonidine or alpha 2 agonist. So this is something centrally acting, and this is a very good medicine for control of blood pressure. So there are many more medicines which we do use for control of blood pressure, but these are the three or four medicines which we have observed commonly being used in these patients. Now, coming to an important question, the question raised by you about diuretics. Now, diuretics are they are commonly recommended drugs, especially in early stage of chronic kidney disease, stage 3 or 4. However, diuretics, there are two types of diuretics. One is thiazide diuretics, and second is loop diuretics. Now, loop diuretics are not a very popular antihypertensive, especially furosemide, because that has to be administered frequently. So they are more used for fluid removal or diuresis, like furosemide. However, thiazide diuretics are very popular because they can be used like once a day, and they are very good antihypertensive medicines. Now, the commonly used thiazide or thiazide-like diuretics are chlorothiazide, hydrochlorothiazide, chlorothalidone, or indapamide. Now, these are a very commonly used drug um, uh, for stage 1, 2, 3, especially up to when the GFR is more than 30. We tend to use this drug. Now, when GFR is less than 30, we tend to reserve this drug because it has its own side effect related to sodium and potassium. So these are the commonly used diuretics. In addition to this loop versus thiazide diuretics, we also use potassium sparing diuretics like spironolactone or mineralocorticoid receptor antagonist. Now, this is also a commonly used antihypertensive, but again, it has a side effect, a prominent side effect of high potassium hyperkalemia. So we use it very carefully with careful monitoring of potassium in these patients. So the spironolactone and eplerenone, these are the two medicines which we usually use in these patients with resistant hypertension. However, this can cause hyperkalemia, and so we have to be very, very careful in using this.
Thank you for sharing that, doctor. And I think it is so valuable to get a breakdown of these complex decision making process, because I feel a lot of clinicians might be facing this issue, or it would be very difficult for them to take this decision. So thank you for breaking that down for us. So now, beyond medications, as you already mentioned about some non-pharmacological applications, so could you talk a bit more about the role of sodium restrictions or other dietary modifications in controlling hypertension in CKD patients?
Correct, correct. See, dietary modifications has to be followed whether you are taking medicines or not taking medicines in someone who has hypertension or someone who want to prevent hypertension. Now, the common is, of course, the salt restrictions. Now, salt plays very important role in causing hypertension in general population. And nowadays, with easy availability of junk food, easy availability of snacks, which is actually has a very high unacceptable quantity of salt, the hypertension is on the rise overall. So salt restriction is very, very crucial for controlling blood pressure. Now, how much you should be restricting? Now, one pinch of salt is approximately 1 gram of salt. Like if you take a one pinch of salt, it is 1 gram of salt. In a hypertension patient or someone who has hypertension with other organs like kidney or heart or any other organ damage, usually we don't allow a salt intake of more than 2 to 4 grams in a day. So it should not be more than that in 24 hours. So you have to cut down on everything that is high in salt, whether it is pickles, whether it is papad, whether it is chips, or whether whatever it is there which has lots of salt. So that has to be cut down. This is the most important part of blood pressure control. Now, in addition to salt control, a weight loss by any is going to help uh, controlling your blood pressure. So whether you do it by exercise, whether you do it by diet, or any other means, it's definitely going to control your blood pressure. Many a times, even a bariatric surgery has been advised to control all these complications. So weight loss is another important thing. And if you try, if you it is easier if you try to do it as much naturally as possible with the help of diet and exercise. Now, there are certain habits like smoking, tobacco, alcohol consumption. These are all invited problems. So, these are all going to trigger hypertension or worsen a pre existing hypertension. So, limiting alcohol intake or stopping tobacco or smoking definitely helps for control of blood pressure. So these are something which are related to our habits. I know it's very, very difficult to break these habits, because most of the time someone who has smoked or has been consuming tobacco for years together, when it develops some complications, we tell them to stop it all of a sudden. And these are the habits which are difficult to break abruptly. But then there are various methods, there are various associations which will help in controlling. Sometimes we suggest to help to visit a psychologist so that the mindset is changed, and importance of stopping these bad habits is re-emphasized. And we haven't come across any person who does not have stress nowadays. So less or distressing yourself by any means, whether it is meditation or yoga or any other maneuvers, definitely will help in controlling the blood pressure. Now, the commonly suggested diet, an additional diet which we recommend, all the associations recommend for control of blood pressure, is called as DASH diet. dietary advice to stop hypertension, DASH, dash diet. Okay, now this is a specific diet which is more in vegetables, more in fruits, lot of liquids, that will control, that will minimize the salt intake, and that will help in controlling the blood pressure. But remember, this may not be fully applicable for end stage renal disease or a hemodialysis patient, because this diet mentions to for excessive consumption of fruits, which usually we don't suggest in patients with end stage renal disease for the fear of hyperkalemia. So these are 5 to 6 points which everyone, as a general person also, as a general practitioner also, as a nephrologist also, should remember and discuss, in addition to the medicine consumption, for control of blood pressure in these patients. Yeah.
Yes, that was a very practical advice, and I think along with the medications, these steps also should be taken to get the utmost control. Yes, 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 yes. So now, in cases of resistant hypertension with CKD, when do you decide to shift from monotherapy to combination therapy, and what factors guide your selection?
That's a very practical question, and I don't think any book will find this answer, because this is something which you have been seeing every day, and you have to make a decision based on individual patient. So uh, the the monotherapy, most of these patients with chronic kidney disease, they do not get controlled with monotherapy. This is our practical experience, although no book mentions that. But no patient with CKD is controlled with a single medicine. So most of the time we have to add at least 2 or 3 medicines, sometimes even 4 medicines, to control the blood pressure. Now, as I said, we have a target, a goal of blood pressure in chronic kidney disease patient, and it is somewhere around 130 by 80, 130 of systolic and 80 of diastolic in chronic kidney disease, especially in someone who has advanced CKD or on dialysis. So we need to control the blood pressure with as many medicines as required until it comes down to this particular range. So whether it is one medicine, or whether it is 2 medicines, or whether he needs 5 medicines, we need to control the medicine. We need to control the blood pressure. So we always go by the target blood pressure. That is most important. Many a times we change the medicine from one medicine to another medicine, in case if patient is developing a side effect of the medicine, like many a times calcium channel blocker can cause swelling in the legs or tachycardia, so we may have to change the medicine, although it's controlling well. Beta blocker can have bradycardia, so in case someone has a bradycardia, we may have to switch the medicine. Some of the medicine, as I earlier mentioned, ACE inhibitor or ARBs, they can cause hyperkalemia. So someone who has a chronic hyperkalemia or intractable hyperkalemia causing ECG changes or frequent admissions due to hyperkalemia, we may have to switch the medicine from that particular group. So there are two important things which we consider. One is the target blood pressure, and second is whether patient is developing any side effect of these medicines. There are additional factors also which we decide when we are combining the medicine. Like if someone has a high blood, a cardiac disease, or cerebrovascular disease, we tend to add beta blocker or a diuretic in these particular group of patients. So these are all the factors which we try to see and make a decision based individually, depending on the patient. Yeah.
So it is quite personalized, I would say, and it also depends on the other, if they might have other comorbidities, and it might interfere with that also. It depends on that.
Yeah. 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 Yeah.
Yeah. So now finally looking ahead, what advancements or breakthroughs do you foresee in the management of hypertension in CKD patients?
Yeah. Looking at the advances, there are multiple experimental therapies, I would say, and one therapies which we have been using, very rarely used, I would say, but it is been used is renal denervation. Renal denervation therapies. We cut down the nerves related supplying the kidneys. Now this is a surgical treatment. Sometimes we use a radio frequency ablation and do this. This will try to control the blood pressure. Again, I'm saying it will try to control the blood pressure. It will not 100%, because this will control the blood pressure which is related to sympathetic overactivity. So that is one of the reason for hypertension in CKD patients. So sympathetic overactivity can be tackled to some extent by renal denervation treatment. There are newer molecules like endothelin receptor antagonists are also in use, but I would say these are something which are not easily available, first of all. And their practical use is not studied in a big pocket with scarcity. The use, it's not that encouraging for someone to use this medicine, because their practical utility is also limited. So these are a couple of newer or advanced things in treatment of hypertension in chronic kidney disease. However, the cornerstone still remains the conventional, as I discussed. One is diet, second is the medicines which we are using, and third, in patients with dialysis or end stage renal disease, is a regular hemodialysis. So these are the important things which will help in controlling their blood pressure.
That is an exciting prospect as well, I feel. Now, as we end today's session, Doctor, I would like to ask one last question from my end. Would be, what would be that one advice that you would like to give to the upcoming nephrologists or the ones who are the budding doctors from your experience?
Yeah, this is very good question. The newer doctors, the one advice which I would like to say is, see the with more and more advanced technology, newer and newer medicines are coming, whether it is nephrology, whether it is cardiology, whether it is hypertension or any other field. Uh, but the interaction with the patient, the discussion with the patient is equally important even now, and it will be equally important even after 1,000 years. So many times the like like as for hypertension, many a times the root cause of hypertension or uncontrolled hypertension you may identify just by talking with patient or patient's family. Sometimes patient may not disclose, but patient's family may reveal something which you should be knowing. So I think a proper discussion with patient in every visit is very important. Instead of just adding a new medicine is very easy, um, but controlling may be still equally difficult even with newer medicines. So my advice would be a good discussion with the patient, and a non pharmacological intervention for control of blood pressure. uh, they were equally important 100 years back. They are still equally important, and they will be equally important in another 100, 1,000 years. So I think that would be my advice. Of course, you have to stay updated with the newer and newer treatment. You need to know all the newer treatment modality, but the conventional treatment should be given equal importance.
That is such a beautiful advice, Doctor. And I think communication will still be the key in coming years with the advancement in technologies as well, I feel.
Exactly. Yeah, yeah.
So, Doctor, thank you so much for sharing your expertise on this crucial topic today.
Yeah. Thank you, Hetvi. Thank you for having me on this and letting me share my views about hypertension related to chronic kidney disease. I hope this discussion will help the upcoming doctors, not just nephrologists, but someone who is treating hypertension. Um, uh, and they will take home some messages from this talk. Yeah.
Yes, absolutely. I feel that too. And for our listeners, this conversation has offered valuable strategies and considerations to enhance patient care in this challenging field. And lastly, Doctor, thank you. And we're incredibly grateful to have had you here, and we look forward to seeing the impact of your work in nephrology.
Thank you. Thank you very much. Yeah.
Thank
Bye.
you. And remember, if you're a healthcare professional who is eager to delve deeper into medical topics or have questions, do not hesitate to join us on the MedSynapse platform. MedSynapse platform is not just a resource, it's a dynamic space where you can connect with your medical peers, participate in meaningful discussions, and contribute to the ongoing evolution of healthcare.